Hi, Robert Cerfolio from New York City. Hope everybody is doing well. So this is a fascinating case. We're going to show you a lot of CAT scans because that's part of the story. This patient has a huge squamous cell carcinoma, was not resectable at the time. He initially had T4 disease almost in the esophagus, in the pulmonary arteries, in the vein, in the right lower lobe vein. So it was treated with radiation and chemotherapy and immunotherapy. Never going to go to the operating room. And then he developed a terrible problem with infection and pus and some hemoptysis. And so we were forced to operate. Look at the coronal section. You see the abutment of the PA. And again, many of you would say, well, this has to be done open. It's 18 centimeters. It's, a gigantic tumor. It's almost in the carina, etc. How can you possibly control the vessels? That's what we get. How can you control the vessels on something this big and do it robotically? Well, the answer is, let's watch the video together. So yeah, it's stuck. So you start off getting in using, VATS techniques and just creating space. Now we're looking down, putting in the CO2 port. You work where you can see. Here we are using the spatula, which is great for taking adhesions down. And no, we do not like it since it's monopolar with a larger spark gap ratio. Dissecting anything out. Why would you dissect something out with a spatula or a hook? We can use a bipolar that can both dissect and cut and grab. So we only use the spatula for taking adhesions down. But you see, this is just plastered. And you're going to see this is by no stretch of the imagination an R0 resection. Not even close. But this is a suppurative, infected, dead lung with pus and blood. And it's taking the patient's life. He's sick and septic. Got rushed to us, incredibly ill with hemoptysis. This is an urgent, not emergent, that's not really a good word, but urgent toilet pneumonectomy. So this just shows you real life. And we didn't do this in 2 hours. This took 4 hours. In any event, we will show you how we get to the vessels. You can't get to the vessels until you see them. You got to peel everything off the diaphragm. You got to find the pericardium. But this shows you how we just keep creating space, working patiently. You got to stay out of bleeding, so you can't let these chest wall lesions bleed. You got to tap them all. You can see here I'm in a little bit of trouble. It's a little too bloody. And you got to be able to control this. And look, there's tumor just plastered down to the esophagus. So we're going to put a scope down the esophagus and then use the ICG camera. We don't give ICG. You don't need to give ICG. But you can see that we're leaving tumor here all over that posterior mediastinum, a little bit of tumor because we knew it was going in the chest wall. We know it's going to be on the goose. We know we're not going to get a complete resection. We're trying to get this out to save his life. This is the reality of a toilet pneumonectomy and doing a non-R0, R1, almost even an R2 resection in a patient who's critically ill with hemoptysis with pus pouring out of his chest. So now we're going to open the pericardium. There's the phrenic nerve. We now go to a bipolar instrument, which is what we like to use pretty much exclusively for routine lobectomies. We don't use the spatula or a hook. Open up the pericardium. There was question of tumor involving this vein. You saw in the first CT scan with contrast, there was almost invasion here. But after neoadjuvant therapy, it got a little bit better. And we're going to demarcate the vein and then quickly get around that. Now, you've heard me talk many times. We don't like to take the veins first until we do the fissure and everything else because of congestion. Here you have no choice. And if there's massive hemoptysis, you divide the airway first. But his hemoptysis wasn't bad. We bronched him. We cleaned him out. Single lumen went to double. And he's not really bleeding. So we're out of his mouth. There's pus coming out. So we're going to take the veins and artery before the bronchus. And this video is just going to show you how to control the vessels. That's a blue load on the inferior pulmonary vein coming from robotic arm 4. Now the EGD going down the esophagus. And yeah, we're right on it all over his goose. But as long as we leave a little mucosa, because we definitely had to take some of the muscle of the esophagus, it's okay. Now we're going to dissect out the superior pulmonary vein and the middle lobe vein concomitantly. Again, we like the bipolar because you can grab, dissect, and burn as opposed to a spatula or a hook. Assistant doing a nice job actively helping us. We think the assistant should be active and not passive. You obviously have to be very careful because you get into bleeding. Sure, you could pack and open, but with a tumor this big, it may be difficult. So you want it to go a little bit slower than usual here. And you can see our intra-pericardial versus extra-pericardial approach. There's the superior pulmonary vein. Now, we're not going to bring the stapler in from 4. Well, it should be 2. I hope we use 2. But yeah, good. The stapler comes in from 2. Good. I agree with this surgeon. That's us. So now we're taking 2. Again, a blue-loaded stapler. Not a white. It's too thick. And now we have the superior pulmonary vein. And here's where everybody gets nervous, and I get it. We get nervous too. Because you can't make a mistake here. So we're going to try to climb over the top, just barely get over the top, and identify the top of the PA. When we do an intrapericardial dissection, sometimes you have to get the cava out of the way. You want to see the azigocaval junction. You want to see the whole A1, A3 trunk, and the rest of the PA going to the middle and lower lobe. So I'm not doing a great job here, let's be honest. That's me operating. It could be drier, could be faster. Okay, there we go. That's a little better. Now we're getting here, if you look at the 6-minute and 13-second mark, which is where hopefully you are, we're digging out. That's the A1, A3, and that's the azigus just under my left hand. And now I'm going to take the whole PA off of the cava, and you can just grab with your left hand and dissect that all off. I hope we show us doing that because I did that during this case. Excellent. Well, I guess we didn't, but you can get around the entire PA off the cava. Now you switch and put a tips-up fenestrated grasper, which is what I like, especially on the left and right side to get around the main PA. You can use a Raytec here. I don't think you need one. You see daylight, and you know that's safe because you see the A1, A3. You're below the azigus. You're lateral to the azigocaval junction. That's safe. Plow through it. You got it. You're then going to double vessel loop this so you can make it a little bit smaller, which is what we're doing here. And now you got to get a stapler around it, and it can be very difficult robotically. So sometimes you use a handheld stapler, and you have to flip the lung up to get that stapler so you're not putting tension on it. I think you can put too much tension on the PA, trying to get the stapler and giving the lung exposed beneath where we were. So now we're lifting it up, where I think it's much safer to come in this direction to get the pulmonary artery either from 4, or in this case, we used our assistant with a handheld coming through the access port, so I didn't lose any of my hands. And I think this is the teaching point here, how you can do the entire operation robotically and control the vessels. Thank you, Robert James Cerfolio. Happy to help you. Let us know how we can serve you better. Hang in there, stay mentally tough, be resilient and persistent. You can do these robotically. You all have the talent. Thank you for your time.